have the Symposia 2 Early Bonds and Challenges. For that, I would like to call upon the moderators, Dr. Anupama Reddy, Dr. Padmaja, and Dr. Shashikala. And the first speaker is Dr. Jyotsna, who will be delivering on the golden hour in breastfeeding, the foundation of bonding. Request you all to please step onto the stage.
Good afternoon, everyone. Thank you, LAMBCON, for inviting us to chair this session. I invite Dr. Jyotsna, who is a consultant obstetrician and laparoscopic surgeon and a very dear friend. And she's the secretary of Hyderabad chapter of ISOPAP. And she is very good at managing high-risk pregnancy, minimally invasive gynec surgery, and fertility enhancing surgeries. Her topic for today is, would you introduce the topic? Yeah.
Topic for today is the golden hour in breastfeeding, a beautiful subject to think about. Thank you.
Thank you to the chairpersons. Thank you to the organizers for having me here. I represent ISOPAB, Indian Society of Perinatology and Reproductive Biology. And this is a topic that is related to us obstetricians and the pediatricians when it comes to breastfeeding. While globally the rates of exclusive breastfeeding have increased to 48%, they're still far away from the target set by the Global Breastfeeding Collective, that is 70% by the year 2030. In India, the exclusive breastfeeding rates have definitely shown promise and increased to 65% in 2015-16 to 76% in 2019 and 21. But the prevalence rates vary according to geographical region and some social factors as well. In spite of all these encouraging trends, the rates of continuation of breastfeeding decline by 6 months, and there's a clear opportunity during the antenatal period and the postpartum period for us obstetricians and midwives and all the supportive staff who come in contact with these mothers to begin the early initiation of breastfeeding. Globally, when you look at it, you know breastfeeding is at the core of the 2030 Agenda for Sustainable Development, and it's linked with all these components of ending hunger, malnutrition, and improving health and well-being, ending poverty, promoting economic growth, reducing inequalities in child health status, education, gender equality, sustainable consumption. So when you look at it, it seems like it has a link to almost everything that you want to improve in the world. But this is possible if we, as obstetricians, focus on the initiation of breastfeeding and continuation. That's where we have to remember that initiation and continuation of breastfeeding rates are not so great because by at least 20% of them stop feeding after the first month, and another 8 to 10% stop feeding even before the 6 months is up. At the end of an year, only about 20% continue to breastfeed. So continued breastfeeding is inevitably linked to early initiation. And it's been seen that infants in whom breastfeeding was initiated within 1 hour after birth showed reduced odds of being exclusively breastfed at 6 months compared to their counterparts. So this is where the importance of the golden hour. The golden hour refers to the first hour after birth, and this is the crucial time when the mother and baby share their first intimate moments, initiating a bond that's not only emotional but also has significant health benefits. It's during this hour that the first breastfeeding should be initiated, and this sets the stage for successful continuation. Benefits of early initiation of breastfeeding, we all know. To the mother, it helps to stabilize the heart rate. To the baby, it helps to stabilize the heart rate and breathing, maintains the blood sugar, and stimulates the breast milk let-down reflex. Early latching promotes proper attachment and suckling technique, increases the milk supply and duration of breastfeeding. It also helps to keep the baby warm and helps the mother and baby to develop a strong bond. To the mother, definitely there are advantages. The first thing is reduction in the risk of postpartum hemorrhage as it stimulates the release of more oxytocin and helps uterine contraction. But the benefits of breastfeeding extend far beyond this golden hour for the mother. There is a reduction in risk of diabetes, cardiovascular disease, and breast cancer for the mother in the long term. What are the factors affecting the rates of early initiation? First, lower educational attainment of the parent, suboptimal health conditions, complicated pregnancies, cesarean delivery, and that's where we all obstetricians come into play, where we encourage more natural births. Cultural practices such as discarding colostrum, etc. in few communities, these all can lead to the non-practice of early initiation of breastfeeding. So challenges to long-term breastfeeding momentum include the lack of sustained information and support for mothers on the art of breastfeeding, such as latching, positioning, demand feeding during breastfeeding, etc. Obstetric complications faced by the mother like PPH, neonatal factors like prematurity and low birth weight, where a baby is shifted into an ICU, fetal anomalies such as cleft lip, cleft palate, and inadequate maternity leave also prevent a mother from continuing breastfeeding. Underdeveloped institutional policies like not having a baby-friendly environment is a big challenge to continued breastfeeding. So it's in this regard, to encourage continued breastfeeding and early initiation, a lot of international bodies have issued statements, and there's a guideline to protect, promote, and support breastfeeding published by the WHO, which includes the baby-friendly hospital initiative, etc. So how do we achieve this early initiation of breastfeeding in all our delivery rooms? Because baby-friendly hospital initiative started to train and sensitize staff regarding early skin-to-skin contact of baby with mother and early initiation of feeding. So all these principles of baby-friendly hospitals, if they are followed to the letter, I think we will be reaching our aim of early initiation. This requires a conviction from the side of all of us as obstetricians and the staff working in our labor wards. What we all can do is to educate, support, and counsel about breastfeeding right from the antenatal period, and to help improve the likelihood of early initiation of the breastfeeding. Counseling must be sustained postpartum. It's not enough to just talk in the antenatal period but not give them any support in the postpartum period. If you cannot do it personally, it's good if you can develop a team who can provide this information and support to the mother. For all institutional deliveries and births assisted by healthcare professionals, counseling for breastfeeding must be provided and should include communication of the benefits to both the baby and the mother's long-term health. Healthcare professionals should enable the principles of the Golden Hour and WHO recommendations and support mothers to initiate breastfeeding as soon as possible after birth. Even in an LSCS, you can encourage your staff to bring the baby and do the first feed on table while you're suturing. Additional support for special cases like in cesarean births, preterm deliveries must be provided within all health systems. What else can be done, not as individuals? Governments, health systems, medical schools, and postgraduate training programs should pursue capacity building, training, and continuing professional development programs such as this LAMBCON for healthcare professionals who may lack the knowledge, skills, and confidence required to assist patients who have difficulty in breastfeeding and to dispel myths and misconceptions about breastfeeding. Public health programs to improve health literacy and knowledge about breastfeeding, and enabling environments and policies that ensure that it can be continued even when working mothers return to employment. So the take-home message is that we, all of us as obstetricians, as pediatricians and staff should recognize the importance of the golden hour after birth and initiate feeding early. Educate the parents, the nurses, and the supportive staff to give support in antenatal and postpartum period for continued breastfeeding. Thank you very much.
Thank you very much, Jyotsna, for a very succinct presentation. Yeah, I remember when Professor Nagaraja Rao sir was our neonatologist in Nilofer. Way back in the early 90s, we had initiated the baby-friendly initiative. So yes, for many years we've been within half an hour starting the breastfeeding. One thing I think we all need to be very fanatical about it. You can't just say, okay, I will do it. You have to do it almost like, like a fanatic. Only then all those people. I'm very happy with this conference because there's so many people who are here. You go back and you be fanatical about it. That's how I think there's the only way we can spread it. And you want to add something?
So that's a wonderful presentation. Please sit down. Yeah, I'll give it to Mike. See, one thing is that, I find that in the LAMBCON or any kind of, this kind of, meetings, we don't have adequate representation from the obstetricians. We find that this is breastfeeding conferences or meetings or mostly pediatrician nurses. It is, in fact, it goes into the purview of the obstetricians more than that of the pediatricians.
Absolutely.
Because they stay with you for 9 months. They stay there and I don't know how much time you spend with them for the counseling. If they are adequately prepared, if they are adequately sensitized, if they are told about how to hold, how to position, how to start, the entire mother, husband, the pregnant lady, the family, then the job at the time of birth is very simple. If you start counseling at the time of birth, everything is new to them.
True, sir.
So, I think there is a lot of changes which have to come in the antenatal checkups, wherein a lot of things have to be done. Yeah, I'm sure you're doing it, but still there has to be, I would need that there has to be more than, there has to be better representation in this kind of conference.
No, I think I disagree with you because from the time the antenatal care starts, we talk about the preparation of the breast, the nipple care, everything, and then about breastfeeding. And I also talk about the economic benefits of breastfeeding. Actually, if we charge each mother the amount of milk she is producing, the amount of milk produced by all the mothers in India is equal to the amount we spend for our petroleum imports. So can you imagine how much the women are doing in spite of it being 50% or 60% breastfeeding? So I tell them this is how much you are going to contribute, not only of course for the child, for the reducing of morbidity and mortality, but by feeding the baby, especially in government setup, we get all poor mothers and they are saving on their...
Practical aspects, because everything has to be taught to them. Everything, because after birth there is no time. There is absolutely
No, we talk about the various positionings, how to position the baby, different baseball method and all that. Even twins. I have had a mother of twins who breastfed both her babies for 16 months successfully. So basically, and second thing
Sir,
is
there are a lot of us who are fanatic about early initiation and breastfeeding. And some of us do take classes for parents, not just the mother, for the husband and the family, how to support the woman during. I've been hearing all your pediatricians talk about how the spouse can support. All I have to say is leave the mother and baby alone and go do the rest of the housework. She'll manage to breastfeed. That's all.
One more thing is in this whole process, I think what you mentioned, skin to skin, zero separation. That is also something that you need to do in the labor wards, completely zero separation right from the beginning, deliver on the mother's abdomen. I think if you can practice that, early initiation also comes in along with it. Thank you very much.
Like a relay race, what you have to remember is you have to pass on the baton. We are passing on the baton to the pediatrician. So in between, now we have all these lactation experts who should also be well versed and who should take over from us. In between, they should act like a connective. See, you cannot break the continuity from the obstetrician, pediatrician, in between the lactation consultants. All it has to be seamless. Only then this can be possible.
Ma'am, one moment I want to add. I wish more gynecologists, more obstetricians are as passionate as our legendary Dr. Shashikala Garu. Like ma'am says, they spend a lot of time. That's very much true. But the herd of such people are very less, ma'am, nowadays. Unfortunately, those the young obstetrician, they're not spending time. Most important, the mother-in-law's role. They're not looking at mother-in-law's re-education of mother-in-law. That is where the fault is happening. By the time the baby is born, already mother is primed up nicely. You don't know anything, I know better, I've already brought up you. So that is where the things are happening. The knowledge gap is missing because of that. As you say, passion is what is important, because I am very passionate, just as you are there as far as breastfeeding is concerned. In my entire hospital, I don't even have a single photograph of any bottle. And I spend time in educating you, despite my spending only 2 minutes for a patient. But for any first newborn comes, I spend 10 minutes. So, as you said, fanatical, passionate, and obsessive, and forceful, emphatic message, all that matters. Thank you.
So I'm so glad that we were passionate about bringing obstetricians on this platform. Thank you.
Thank you so much.
So, now I call upon our speaker, Dr. Madhumati, to share her insights on the topic breastfeeding and perinatal mental health.
Good afternoon, ma'am. So, this is Dr. Madhumati. She's a senior consultant obstetrician and gynecology of the Apollo Hospitals, Hyderabad. Her areas of interest are high-risk pregnancy, adolescent gynecology, and she's an executive member of the ISOPAB. Over to you, ma'am.
Thank you, ma'am, for that introduction. At the outset, being part of ISOPAB, I first of all congratulate LAMBCON on this beautiful conference and for involving ISOPAB right from the beginning. We're really happy to be here. And what better than having Dr. Shashi being one of the chairpersons. She's been my teacher and my mentor, and yeah, she's like family to me. So this is something we've all been hearing for the last 2 days over and over again, what WHO is recommending. Mothers should begin breastfeeding within the first hour of life. Jyotsna just now said that, and there was such a lot of passionate discussion and debates about it. And exclusive breastfeeding for 6 months is what we should be encouraging, and if possible, they should be continuing it through age 2. She already also told us that it also protects the mother against chronic diseases, and there's also psychoneuroimmunological benefits, which means it reduces anxiety and depression. Now, what do we mean by perinatal mental health? So, condition of mental illnesses occurring during pregnancy and a year following birth. Now, let's not hide away from this. Let's not push it under the carpet. The global prevalence is as high as 15 to 25% of a new condition occurring or a recurrence of a pre-existing condition. And there can be anything from something as maybe, I can't use the word simple, but maybe mild, as anxiety to depression, postpartum psychosis, PTSD, OCD, tocophobia, a word I learned while preparing for this talk. Fear of pregnancy, fear of childbirth, fear of what will happen during this pregnancy. Bipolar disorders, eating disorders. So this was the recent literature review about mental health benefits of breastfeeding, and let's quickly go through some of these. So what does lactation and skin response bring about in the mother? So we know that ACTH and glucocorticoid is associated with the activation of the hypothalamo-pituitary adrenal axis, which is the stress pathway in the brain. Psychological stressors activate this HPA axis, increasing cortisol production, leading to increased anxiety. What has been observed is that there is decreased ACTH in breastfeeding mothers, thereby decreasing their anxiety. So longer duration of skin-to-skin contact reduces levels of maternal cortisol, decreasing postpartum depression and anxiety. So that is one great benefit that they have with their mental health. What is the relationship between improved self-efficacy and bonding? Now, self-efficacy to the mother is inversely proportional to postpartum depression. So, breastfeeding has proven to be crucial in the development of the mother-infant bonding. This we already know. And it has been seen that infant's touch of mother's nipple positively influences the mother-infant relationship during the first 4 days after birth. And that is where the challenge is. We all know that there isn't much letdown happening in the first 4 days, and there's just colostrum, and she's so overwhelmed, and the family is telling her, okay, start formula feeds. And this is where all our encouragement, all the counseling that Dr. Ravi Shankar was talking about that we should be doing is tell them that this is very important, because then when this happens, it also alters the maternal neuroendocrine function, which means it is helping her to allay any anxiety. How about breastfeeding and sleep? Now, this is something very interesting. We know that less sleep can negatively affect mother's physical and emotional health and increasing the risk of postpartum depression. Sleep is essential for mother's milk supply. Potential association is there between deep sleep and the prolactin levels. Now, contrary to the belief where we all keep saying that because she's breastfeeding, she's losing out on sleep, what has been observed is that breastfeeding women slept 2.6 hours longer than women who bottle fed, because this is good quality sleep that we are talking about. How about early cessation of breastfeed? So what has been observed is that prenatal depression is associated with late initiation of breastfeeding, whereas postnatal depression is associated with early cessation of breastfeeding. Now, this is a bidirectional relationship, which means breastfeeding reduces incidence of postpartum depression, and depression may cause early cessation of breastfeeding. Now, what was seen is that the median duration of breastfeeding was just about 26 weeks in women with early onset depression, whereas those without depression were feeding for as long as or even longer than 39 weeks. So that is how it is interrelated. We do know medical conditions also may affect mother's ability to breastfeed, like thyroid disorders, diabetes, PCO, post-breast surgeries, obesity and all of that. Like we were just now talking about support and awareness, yes, lack of support and awareness also has been cited by many new moms in a self-reporting study that because there wasn't enough support, there was early cessation of breastfeeding or she couldn't continue. Now, this was a very recently published article where they reviewed through 17 articles with breastfeeding experiences of women in perinatal mental health problems. And as they were reviewing these articles, the themes that came out, there were a lot of themes and sub-themes. The main themes that came out were the vulnerabilities that these women face, what are the positive outcomes and what are the challenges. So the same thing is in a pictorial representation. You have the mother with perinatal mental health. She's trying to breastfeed, but she has these vulnerabilities. She may have positive outcomes, but then there are also a lot of challenges that she faces. So what are the vulnerabilities? The expectation versus reality. Very commonly, mother, mother-in-law, whoever, friends, they will just say, oh, it should be instinctive. You've been pregnant for 9 months, you've given birth to a baby. Breastfeeding should just be instinctive. New mothers are unaware of the potential complexities of breastfeeding during early weeks due to paucity of antenatal breastfeeding advice. Point well taken, Dr. Ravi Shankar. Yes, Dr. Shashi is definitely counseling. We are counseling. We are working in hospitals which actually has a proper antenatal class and, lactation consultants are seeing them. But this is not happening across the board. It's not happening everywhere. So there is definitely paucity of antenatal breastfeeding advice which needs to improve. Now, what about her self-perception as a mother? So, there is this general feeling that you must breastfeed to be a good mother. So there is, which basically results in self-imposed stress, feelings of inadequacy, feeling very overwhelmed, which leads to anxiety, which will again lead to late initiation of breastfeeding. It's all related. And with all of this, to be a good mother, you should be breastfeeding or it should be instinctive. She starts feeling very isolated. And with this also comes reluctance in seeking help. And so we have underreported cases. So there are a lot of women who have some degree of postpartum anxiety. And if we don't address it, if we don't keep the conversation open, it is just something that she's not going to come out with, and then we will not know that she's actually needing the support. Positive outcomes we already spoke about. We spoke about bonding and closeness. The confidence that the baby is being comforted is something that she, really makes her happy, makes her stress levels come down, especially if she's already having some mental health issues. And then the sense of achievement, she feels that at least there's something that is giving her a sense of control. For example, she doesn't have control over her own mental health illness. She might have had a traumatic birth experience, or she may have had some other additional, medical disorders which came on in the pregnancy. All these are not in her control, but when she's able to successfully breastfeed, then at least she has a sense of control that she's able to do something good towards the baby. Challenges. Now, this is where, which is very interesting. So there is this, they are striving for control, and especially in some particular mental health issues. Like for example, in a woman with the eating disorders, they may want to, they may consider stopping early because they want to get back to that control over their body, and which means they want to get back to purging, strenuous exercises, not eating right, and hence, this may kind of push them into early cessation of breastfeeding, which is where they will require our support. On the contrary, you have women with OCD who even beyond 6 months do not want to take on, additional feeds for the baby because they have fear of contamination. So we know that the baby will be undernourished if it's only exclusively breastfed beyond 6 months also when the baby needs something more. So again, these are challenges that we will have with women who may have OCDs. They also feel that there's inconsistent advice and lack of support from us, that is from health professionals. And this is basically happening because there is a lack of quality evidence, and which means there has to be more work and more studies which goes on this. They have a lot of concerns over their medication safety. They're all on medications. They either don't want to breastfeed because they are on these medications, they fear what it will do to the baby. If we try and change their medications, then they are worried about what will happen to their own mental status. So it's like a very contradictory thing, but then they are worried about it. I'm done. Yeah. And also there's a lot of contradictory information that they feel are coming in from health professionals. So to conclude, we have to accept perinatal mental health illness is a reality, not to be pushed under the carpet. We need to address the issue. We do know that positive breastfeeding experience mediate positive outcomes, but the social stigma attached to being seen as not a good mother while facing challenges with breastfeeding leads to underreporting, and we need to be more supportive towards these moms. And realistic antenatal education is key. We've discussed enough during the last talk to prepare new moms for common difficulties that they face with breastfeeding. Thank you very much for a patient hearing.
Thank you, Madhu. You have covered all the aspects of perinatal mental health in the mother. But I think we obstetricians also are contributing to some extent to this, I feel. Because we are doing so many tests, prenatal, first trimester screening, all these things. Then there is,
and not to forget all the Googling that they do.
Not
so they
only
come actually with a lot of stress as such. I mean, you're
so
right about this.
inconclusive tests, and then they go through one more test, NIPT or amniocentesis, and then till then they are anxious. Then after that we will say fetal echo, then we will say growth scan, then we will say Doppler. So throughout the pregnancy they are going for some test or the other. In the process of trying to deliver a very healthy baby, we are putting the patient through a lot of stress. That prenatal stress is also adding, initiation of breast feeding is not starting. Yes. Then when there is no breast milk coming, again that stress adds on. So all these things. Yeah. So maybe sometimes I feel we need a counselor, psychological counselor in the postnatal period, because they come to the pediatrician for the baby, the mother comes to us, but the bonding between the mother and child, and is there any problem? So we don't as obstetricians have that much time to spend, nor do you pediatricians have. So please.
Beautiful, ma'am. Take every point, and thank you very much. And I have a disclaimer, I'm a pediatrician between two obstetricians. I'm not an obstetrician, but I have to say I'm working a lot with moms. Yeah. And we have a program, we had a pre-conference workshop of Arijanani, which is basically working on all these aspects. I think we need to wake up to these facts. 15 to 25%, as you mentioned, I'm sure you're a high-risk obstetric expert. It's more than any other morbidity that a mom can have. And what Madam has just described, the number of tests, the number of ultrasounds, one intracardiac echogenic focus and the mother goes berserk, all these probably we are seeing at the end where we are working with mothers, trying to allay these anxieties and bringing out the best for the fetus and the future of the child. Yeah. There is a lot of impact of all these perinatal.
There is also a lot of taboo in our country about going for counseling, to step into a counselor's chamber. And, if we are able to kind of get that taboo out, otherwise they don't want. So basically, like Dr. Shashi was saying, we become the counselor also. Because through 9 months, or sometimes if this is the second baby that she's having with us, we've been knowing her for so many years. We become part of their family. And which means we are also doubling as counselors. Obviously, we, one, not trained to be a counselor. Two, may not have that kind of time also sometimes.
Send them to us, ma'am. We work with Ramakrishna Mutt. We have a lot of mothers whom we are trying to help in this subject because it's going to be of paramount importance for our children for tomorrow. Because if we don't deal with maternal stress, we'll have a hell of a problem with autism, ADHD, and all the behavioral problems in our children.
Yes.
So please work on this and we'll help you with it.
Okay.
No, I think you should
Point
also
taken.
train more people from the districts. See, all of them can't come to Ramakrishna Mutt, you know, in the entire state. So you have to train online workshops. Each district, they should have a counseling center. And all the obstetricians should be aware that these kind of centers are available. Because we have to focus on this. Otherwise, we are going, that there's a big lacuna in this area.
Yeah, I just wanted to add up one more thing. One more aspect which brings about stress to the mother and the family is separation of the baby from the mother. When it is an unintended NICU admission, suppose it is not anticipated, you have some issue and all.
Yeah.
So that, or if it is a premature baby. So that way the entire family is in a stress. The mother is in stress. So how do you handle such things? I'm sure that, this actually adds up to a lot of already existing stress. So the child is not healthy and is admitted. So this requires a lot of effort from obstetrician, pediatrician.
A lot of counseling, yeah.
Yeah, so that is also one thing which we need to consider here.
So one sentence, ma'am, Dr. Shashikala Garu, as ma'am says, they listen to the primary caretaker, either obstetrician or pediatrician, more than the counselor. Because our word is taken as a God's word. So we should spend in appreciating the mother, that while breastfeeding, what is happening, and how beautiful the baby is there. You appreciate the mother, and also ask the mother to spread the message to other people who are about to become mothers. So it's a chain thing that create, and it will relax her a lot. So that psychosocial stress will go by appreciating her, by patting her, and all that. Thank you.
Thank you, sir.
I think adding on to what, you want to say something? Sure. So the one thing I think we should all say, and we should all sitting in this room take this pledge, is women are consuming so much of information. We should tell them to stop doing that. Look at any and every screen starting from their mobile phones. I think we all have a responsibility in that way, is what I feel strongly, particularly these days, because what Dr. Madhu said also, they're consuming information consumption is equivalent to emotional diet. And that's why they're all becoming emotionally vulnerable, because they're consuming a lot of information. Anybody has an access to a mobile phone and is consuming a lot of information.
Thank you. I would now like to call upon the next speaker, Dr. Rashna Das, to give away on the topic, Guiding Preterm Babies from Tube Feeding to Breastfeeding. Ma'am, please.
So Dr. Rashna Das Hazarika. Areas of interest are critical care, infectious diseases, and vaccinology. You're formerly founder, HOD, and of the Department of Pediatrics, Shillong, Meghalaya. She's got more than 50 papers she's indexed and contributed to the chapters in books. She's done a lot of extensive research work, and she's fulfilled a lot of administrative responsibilities. And she's the editor of Breeze newsletter in Guwahati, chairperson and scientific committee. I think we'll be here all day if I start reading all that she has done.
I think we should stop.
Yeah, I know. So, over to you.
So thank you very much, chairpersons, respected chairpersons, and the team of LAMBCON. It has been a very enlightening journey these last 2 days. So I'm talking about guiding preterm babies from tube feeding to breastfeeding. So I'll just give you 2 case scenarios. Case 1 is a 30-weeker respiratory distress, 1,000 grams on nasal CPAP. Started on tube feedings from day 2 of life and now currently day 7. The second is a 34-weeker IDM, RDS, again mild birth asphyxia, on CPAP, same started on tube feedings on day 7 of life. And both the families, particularly the mother, want to know when they can breastfeed their babies. I think this is a common scenario we see. And this is very easy for term babies because rooting occurs immediately after birth and they go on attached to the breast like it's a natural phenomena. But for preterm babies, we know that the suck-swallow reflex is present only from 28 to 30 weeks. Rhythmic sucking actually occurs at around 30 to 32 weeks. Rooting occurs at 32 weeks. And the most important thing, the coordination between the sucking, swallowing, and the breathing occurs somewhere around 32 to 35 weeks and varies a little bit from baby to baby. But very nice thing about being born preterm is that most of these reflexes are accelerated after birth. And most of these very low birth weight babies in our NICUs and nurseries are usually fed through a tube in the first few days, and this may extend up to a few days after birth or few weeks. Many reasons are there for not being able to start oral feeding. And as far as oral feeding is concerned in very low birth weight babies, it is an important milestone for the preterm babies and for the doctor who is treating because this is a major discharge criteria of these babies from the NICU. But attaining of safe and efficient nipple feeding skills is a very complex process and it is challenging. See, it is challenging for even term babies as we have discussed in the previous two talks. But it is also challenging, more challenging for the preterm babies and especially those who are high risk. And therefore, they have very large amounts of feeding failures. And it is complicated. The transition from tube to oral feeding is complicated by a number of factors. One is the innate difference in the muscle tone. We know that preterm babies are more hypotonic when you measure the tone in comparison to the term babies. The state of the baby, where they're awake and able to take. The endurance, can they tolerate so much of feeds or shifting them to breastfeeds. And then the interdependent or independent of the suck-swallow breathing coordination. There are many reasons which prevent direct oral feeding. So one of them is the risk of choking and aspiration due to immature neonatal reflexes. And I think that is one which is very scary for all of us with these very, very low birth weight babies. They have latching issues because of immaturity of the reflexes. They have weak suck, shorter sucking burst, and they fall asleep frequently. Then there will be presence of one or the other comorbidities. Most of the babies, usually they have respiratory distress or CNS issues, and then we fail to recognize the hunger cues. So first few weeks are very critical for the growth and development of the GI tract, and studies have shown that if you do not stimulate the GI tract by giving feeding, it will cause mucosal and villus atrophy, and exactly the opposite happens if you can start feeding early. So this is a study which showed that enterally fed animals had very nice villus development compared to those who were not fed. So the picture on top is the one who has been fed, and the picture on below is the one who has not been fed. So the same thing happens to babies. If you feed them early, they have increased jejunal mass, increased enzymatic activity, promotes peristalsis, faster growth, and you can send them off early. So most are started on enteral feeds from day one itself, which we all know as trophic feeds. And we all have known over the last 2 days that mother's own milk is preferred, followed by donor human milk. And I have not mentioned that if these are not available, then probably milk from another mother, which we had a long debate in the morning, and the last is the formula. But we should avoid the formula as far as possible. Most of them who are below 34 weeks or more than 34 weeks with some problem will be on tube feeding, and those above 34 weeks will probably be first on pallidi and then on breastfeeding, depending on the infant cues. So the usual factors deciding transition to oral feeding depend on the age, the gestational age. So we try usually at around 30 to 32 weeks post-menstrual age. They should be in good health, that means off respiratory support, no apnea. And mostly this is done by a trial and error method. And we also have the pressure to discharge these babies early because of economic constraints. So this also influences the time of transition to oral feeding. And 30% of these babies experience difficulty in transition to oral feeding, and this is higher in the sick preterm. So what are the objective measures to decide or to guide the transition from tube to oral feeding? So there are some factors and there are some maturation, the mature gestation and state of health. So one is the gestational age at birth, the birth weight, if presence of maternal comorbidities which add to the neonatal comorbidities, is there any brain injury, respiratory status, is the baby on respiratory support, duration of the mother and the baby's separation, because that will affect the outcome of the breast milk, feeding support, whether she has received antenatal or postnatal support, and interventions to support oral feeding like oromotor stimulation, then non-nutritive sucking, and what we are now into, this developmentally supportive care. So in the gestation, actually usually, as I said, we will go at around 30 to 32 weeks, but this differs on baby, from baby to baby, and depends on the added comorbidities. So the parameters that determine the readiness for oral feeding are gestational age more than 30 weeks, saturation should be more than 95% without oxygen, state of alertness which is sustained for at least 5 minutes before attempted oral feeding, and the proper body posture. Rooting reflex should be there. There should be good oral motor maturation for feeding, so the baby should seek the finger or the nipple when the lips are stroked and positions the tongue to accept the nipple into the mouth. So this is what we must observe. There should be long sucking burst with pause for breathing, absence of stress signs, and they should be able to manage a bolus without gagging. So we should recognize the infant feeding cues. There are many ways to recognize them. And then I got this study yesterday from Murki, I think very beautiful, simple study. And this is very exciting because he looked at the sucking behaviors of babies who were on tube feed, spoon feed, and breastfeed babies. And they found that the number of sucks, the grade of the sucks per burst, were best in the breastfed babies, obviously, followed by spoon-fed babies. So the ability of the preterm babies to transit from one mode of feeding to another is determined also by the sucking pattern. And this is, I think, what our nurses do when they examine the babies and they give us a feedback. So how we can allow for faster transition is by doing colostrum mouth paint, adding a few drops of the milk to the oral cavity when the baby is still on the tube feeds to induce the smell and taste, non-nutritive sucking, oromotor stimulation, finger sucking, the feeding, that means suckles on the finger while the baby is being tube fed, cup or pallidi feeding, avoiding bottles, and responsive feeding based on the infant cues. So these are the infant cues. I'm not going into the detail because of lack of time. And we have to understand that when the baby is satisfied and feeding when awake, we should give at least non-nutritive sucking for about 10 minutes every 3 hours, and give the feeding when the baby is in the wakeful state. So this process is accelerated by providing developmentally supportive care and oromotor stimulation. Now about feeding volumes, it is said that you should achieve about 75% of the oral feeding before removal of the tube, but there are new studies which have come up which have shown that you can even start with higher feeds depending on the risk of the baby, and these papers are available. And even early total enteral feeding is much better, and it is associated with less time to full feeds and transition from one mode of feeding to another. This is another trial which has shown that there was no risk of NNEC, late onset sepsis or feed intolerance if you give higher feeds. So practically what we do is we give trophic feeds plus oral mouth paint with colostrum from day 1. Feeds are increased as per the clinical status. We give cue-based feeding and early initiation of non-nutritive sucking. Small pallidi feeds are offered to babies and then the rest by tube feeds. And daily increments are done based on bedside clinical judgment. And finally, we shift from the pallidi to the breast. So the success depends on how these babies are able to engage during feeding, time used to complete, the volume of the breast milk, time to oral feeds, and absence of aspiration and weight gain over a week. So in conclusion, I think this is looks very simple, but you should also read in between the lines that initially we will start with something like tube feeds, trophic feeds, and colostrum mouth paint, then followed by tube feeds, finger feeding, and minimal oral feeding in drops, followed by tube feeding, non-nutritive sucking, and pallidi feeding. Then we shift over from pallidi plus breast, along with monitoring, and finally to breastfeeding. Thank you very much.
Thank you very much. That was such a lucid presentation. I wish you had more than 10 minutes because you covered so much with so much of research. But they were so good. I mean, the last slide especially was so informative. Thank you very much for that. The one catchy word that I heard in the whole thing was allowing us to look at the nurses and allowing us to understand what the nurses feel about the advancement of feeds from, in the NICUs. That is such a beautiful way of
because
starting.
in my NICU, what I'll do is I'll ask the nurse in the round, do you think this baby is ready for spoon feeding or palliative feeding? Then if they say yes, then only we'll shift, or even for increasing the feeds.
I think your attire is very beautiful.
Thank you very much.
Is that from Meghalaya?
Mekhla chadar. That's beyond the syllabus.
I'm sure it's not just the feeding, but the parents going and spending time with the babies, tactile, touching and talking, etc. also helps.
Yeah. I add all that because in developmentally supportive care, that is what we practice. The mothers are allowed in as soon as they can. They will hold the baby, maybe massage, and even give the feeding when they are ready.
The fathers also.
The palliative feeding also.
Mothers and fathers.
Yeah, and father also. Fathers come and do this kangaroo father care.
Excellent. Thank you.
Thank you, Dr. Rashna. I kindly request you to take your memento from the left side of the stage. I now call upon Dr. Venkat to speak on the topic medication use and immunization in breastfeeding. Kindly, sir, the stage is yours.
So first of all, I thank LAMBCON for giving me this opportunity. So my talk is on medications and immunizations in breastfeeding. So the next 10 minutes we'll try to break some myths about this medication and immunization in breastfeeding. So first thing is risk-benefit analysis. So every day we sit in the OPD, especially in this couple of months, we see a lot of virals going on. So when the baby comes, when the mother comes with the baby, so we ask, how is the baby feeding? Everything is fine. So she tells that baby is feeding well, but I have started formula because I am also having fever. So I ask, why you have started formula? So no, I am taking medication, that's why I have stopped feeding. So I think this is a scenario everyone faces in the OPD. Okay. So when I tell her that, so the same paracetamol you are taking, I am giving to the baby also, then why are you stopping feeding? No, I can't take any risk, that's why I stopped feeding. So this is a common scenario we come across in the OPDs. So for the risk-benefit analysis, so what the mother perceives risk is something different, what the risk we perceive is something different. So here, so whenever mother is not giving feeding, so what happens is it causes accumulation of milk in the breast, which causes engorgement and pain. Okay, so that results in, God has given a mechanism beyond which certain point, so the milk can't accumulate in the breast. Okay, thereby it releases certain chemicals called feedback inhibitor of lactation. So this will suppress the milk. So it is a protective mechanism that mother should not have so much of pain. So this is a protective mechanism. But the end result is what happens is the milk output will come down. So here the risk or the problems I perceive is, first thing is the pain and the physical pain for the mother because of the breast engorgement. The second thing is psychological impact of the mother. So whenever a mother comes along with the family, if one bit of doubt we create with respect to medication, that causes lot of psychological impact over the mother. So even when we counsel them, they will be like, mother will be like, I don't know, if something happens, the family will blame me. So that is why I don't want to take any risk. I want to stop for a couple of days. What is the problem? But the problems are, physically she will have a lot of pain. Second thing is the psychological impact will be there. So third one is the amount of milk will come down. And the fourth one is at the end the baby will be devoid of the nutrition, important things which are there in the breast milk. So that has been, baby will be deprived of all those things. So this, if you see the risk and benefit, so the risk is nothing actually. So the benefits are more if we continue breastfeeding rather than stopping breastfeeding. So our main worry is the drug which mother is taking might go into the baby via breast milk. This is our worry. So for this worry, there should be some physiology, some pharmacological rationale. So what are the factors which will allow the drug into the mother's milk? So first thing is molecular weight of the drug. So the lesser the weight of the drug, the more is the amount of the drug which can get accumulated in the mother's milk. And the more the molecular weight, so the lesser is the transfer of the drug into the milk. The second thing is protein binding. The drug is bound to protein, it is less likely to move into the breast milk. The third one is lipid solubility. The more the drug is lipophilic or lipid soluble, the more the drug will enter into the breast milk. So next is pKa. So that is dissociation constant. Here there is important concept called ion trapping. So actually mothers or breast milk is a bit acidic when compared to the plasma. So then what happens is whenever whichever drug comes into the milk, whenever which are weak bases, they get dissociated and the ion gets trapped in the milk itself that can't go back. So that is especially seen with respect to iodides actually. So that is nothing but dissociation constant. Next thing is maternal plasma concentration. The more the concentration of drug in the maternal plasma, the more will be the entry of drug into the milk. So next thing is half-life of the drug. So the lesser the half-life, the lesser is the chances of having the accumulation of drug in the mother's milk. And next thing is timing of the drug intake. Usually what happens is whenever a drug has been taken by the mother, it will take at least 1 to 3 hours for the peak concentration to reach. So this concept is useful for timing the breastfeeding. And the last thing is age of the infant. So with respect to age, if the baby is a premature baby, the metabolical pathways will be very inactive, so more harm can be caused. So if the baby is term baby or a young infant, the metabolical pathways are very mature enough, so it may not cause much problem. So these are all the factors which we need to consider before stopping or before giving your advice to the mother regarding the stopping or withholding of the breastfeeding. So next thing is what happens is these are all the factors which we need to consider. But where we need to read all these things. So we have LACMED database, so which is a free for to read database which is available in the internet. And at the same time, a app is available, by name Lact RX. Initially, the app used to by name LACMED, which has been changed to Lact RX, wherein you can search for the drug and you can see the whatever information you want with respect to drug. You can give a evidence-based advice to the mothers. Next thing is Thomas Hale. So this is even a app is also available and the website is also available, but it's for a paid subscription. The next important thing is eLactancia. So this is a website which is very, very useful, and actually it is a Spanish website, but is available in English also. Here if we enter the drug and if we search for the drug, it will give you in this format, that is whether the drug is compatible or not, if there is any alternatives which you can consider for giving to the baby. All these things you can get through this app. You can give evidence-based advice to the mothers by using these databases. So next thing is there are certain textbooks like Briggs, Drugs in Pregnancy and Lactation. And the last one is manufacturer recommendations. Sometimes we might come across a very rare drug which the availability is not there. So then you can consider the manufacturer recommendations. Next thing is common medications are usually safe. Commonly we use these medications like paracetamol, ibuprofen, antihistamines, proton pump inhibitors and topical medications. Nothing will happen with these things. Especially commonly in this season we use paracetamol. Even for paracetamol people are stopping breastfeeding actually. So drugs which require consideration, so something like antibiotics, we need to time it, we need to see which antibiotic crosses the barrier and enters into the mother's milk. So antidepressants like SSRIs are preferable when compared to SNRIs and TCAs. In benzodiazepines, we can use a drug with lowest half-life and fast-acting drugs. And thyroid medications are usually safe. Anticonvulsants, when there is a choice, they can change to drugs like levetiracetam compared to valproic acid. So there are only this list drugs which are contraindicated. Rest all we can manage, we can see the database, we can see the risk, then we can categorize. These are the only drugs which are contraindicated. So these are amiodarone, anti-neoplastics or anti-chemotherapy drugs, gold salts, iodide and iodine containing compounds, lithium, and radiopharmaceuticals and retinoids. These are the only drugs which are contraindicated as per the evidence. Rest all, or we can have a proper discussion with the parents and we can decide. So coming to the immunization. So with respect to immunization, the important thing is the only theoretical concept is live attenuated vaccines when given to the mother, they can cause viremia or bacteremia, which can be this virus or the bacteria can enter into the mother's milk and can cause infection in the baby. This is all the theoretical concept. But practically what they observed is all these vaccines are safe in pregnancy. If indicated, they can definitely take the vaccine. Only vaccines which are contraindicated during breastfeeding are certain strains of mpox or smallpox, yellow fever vaccines, BCG, there is no proper evidence actually. Typhoid oral vaccine are contraindicated. Remaining all are indicated. If at all indicated, we can give those vaccines. So coming to the key takeaways, so most drugs are relatively safe for breastfeed babies. So remember the drugs which are absolutely contraindicated and understand the principles of drug transfer and check the resources, discuss with mother and especially the family, because only discussing with mother will not be sufficient. We have to discuss with the family also, and majority of vaccines are safe during breastfeeding. Thank you.
Venkat, as always, your presentation was excellent. I've heard you so many times. And
Thank you.
I think you've given us, the obstetricians, a lot of assurance that most of the medications, in fact, but for the handful of medications that you quoted, all of them are safe to be given during lactation and breastfeeding, and even the vaccines as well.
Last week I delivered a patient who is a schizophrenic on anti-schizophrenia drugs. So we asked the patient to take the drug before, after the feed, night feed, and next 4 hours avoid. That's when the peak half-life is there, to avoid feeding. So these kind of small things we give. Supposing there's breast engorgement within 2 hours, then express the breast milk and discard it, and end of 4 hours she can feed. I think that, yeah.
So the only thing I suggest is we should not wait till the engorgement actually. Okay, we can manage. We see if there are 2 drugs are available, we can shift in with these 2 drugs, whichever has less potency to enter into the milk. So in that situations we can flip in such a way that, so at the end of the day there should not be problem to the mother and there should not be problem to the baby.
Thank you very much. Thank you.